Next, I would like to invite Dr. Shane Matthew.
Very good afternoon to all. What anti-VEGF agent do I inject? It's a long talk, but I'm trying to finish it within 10 minutes because I need to tell you a lot of things. So this is the story in 2020. So what has changed from 2004 to 2022? Newer agents with longer duration has come in. There's reduced costs of innovator molecules. Biosimilars are patient supportive offers from pharma companies, thereby the cost of innovator molecules are coming down. Now we have a lesser concern for systemic side effects, and intravitreal injections are becoming CAT trial 5-year results saying that 80% of the AMD patients had active disease by end of 5 years. That means we are looking at diseases where we need to inject patients for decades together. Be it aflibercept or be it ranibizumab or be it bevacizumab, most of their efficacy is almost the same. Theoretically, aflibercept scores over ranibizumab, which scores over bevacizumab, but by and large, if you look at the graph, you know that most of the agents are the same. So and keep injecting, and that gives the best result. The 5-year extension study also told us that the strict regimen, if you give it monthly, that is the best, but it's not always possible. Real world injection strategies, that is commonly what we do in our clinics, is not that stringent, but the study said that even if it doesn't give you the best result, but it has definite visual benefit. So it is okay not to treat as stringent as in a study group. With less So understanding the agents is very important. Dr. Gopal nicely described the newer kid in the block, brolucizumab. Aflibercept, ranibizumab, we know the cost of aflibercept was more, but now they've reduced it. So I prefer aflibercept because it has got better drying capacities, and systemic adverse effects is more or less the same between the groups. And biosimilars are also coming in a big way. Coming to Osidex, the moment you think about a dexamethasone implant, you talk about cataract and glaucoma. I know cataract is reversible, but if you look into the details of glaucoma, 6 to 8% of the patient had glaucoma, but the good news is most of them were controllable with topical medications. So we have 3 treatment regimens for anti-VEGF at least. We have a fixed dose regimen, which is the best, but practically difficult. When we have a treat and extend where you treat with initial 3 monthly doses of anti-VEGF followed by slowly extend the interval of injection by every 2 weeks. But mind you, by every 3 months to 4 months, we keep injecting whether the disease is active or not. But in PRN regimen, you keep injecting only when the disease is active. That means you are staying behind the disease. For example, in treat and extend, you stay ahead of the disease. For me, DME and RVO, the first line is always anti-VEGF agents unless there is inflammatory biomarkers or the patient is undergoing vitrectomy or a cataract surgery along with an anti-VEGF and has a very recent thromboembolic event. I might think of a dexamethasone implant or even triamcinolone. Nowadays, I use less and less of triamcinolone because the propensity of glaucoma is more with that. And I always do a loading dose followed by treat and extend for fresh cases. In CNV, loading dose with treat and extend is my way of regimen, but if there is large PED, if there are mature vessels seen sub-RPE, if the CNVM complex consists of mature vessels, and if the patient needs increased time interval between injections, I would think of aflibercept. If it's not working well, recently I've even started using bi-monthly aflibercept to see whether it is working. Brolucizumab is also a given option at this point. A word about switching of agents or switching from one anti-VEGF to the other. So if there is no response, there is no doubt we need to shift to another agent. But if there is some response, what do we do? In CNVMs, I would definitely switch to another agent after 3 doses if there is only some response. But in DME, I would like to wait for a couple of injections more, because we have seen in DME that there are late responders who will respond in the injections later on. There are situations where in good response cases we still shift the agents. One is the patient's inability to come to frequent follow-up. We would want to use a longer agent which lasts for longer so that the patient come at a later date. Ocular side effects of medicines, of course we need to go to a different agent. Always switch to an agent with a different mode of action and switch to a longer acting agent. But the most interesting part of the talk is, it is not always rosy. It is not always what is seen in trials that matters. In real world, when you sit in your clinic, what are the problems you face and how you decide? I would like to present 4 cases before you. The first case, this case is a case of choroidal neovascular membrane with an occult or a sub-RP CNV. So this patient, I explained all the anti-VEGFs available. Of course, the patient selected to use, you have a pointer please? Okay, sorry. So it might take little more time. So I talk about anti-VEGF to this patient, but the patient is willing to take only a biosimilar because of financial reasons. So what I do is I keep giving 3 injections. The retina is flat and nice. So then I have to make a decision. Should I go with treat and extend regimen, or should I take PRN regimen? I know the disease is responding well. I know treat and extend is the best treatment of choice for him, but I select a PRN regimen. But again, why? Because of his try again. The patient comes back after 1.5 months, I see little fluid. That means there is reactivation of the disease, but it is definitely less than the primary fluid. So at this stage, I consider this patient as a good responder, means the patient responded well to the initial agent, and this is a recurrence. So I would definitely continue this biosimilar in him. I wouldn't change any agent. And sure and certain, he is doing well, but I am repeating injections every monthly. So this is case number 2, where you have a CNVM of the left eye. Right eye, I gave almost 30 injections from 2016, and it is stabilized at 636 vision. Now, me and the patient knows, yes, left eye is going to get at some time, and we caught it very early. 2018, 6.6 vision with metamorphopsia. So again, I discussed the entire anti-VEGF agents to the patient, and she decides to take a ranibizumab because she took that in the other eye. But what happens here is, the fluid is increasing. I mean, giving 3 doses of ranibizumab, but the fluid is actually increasing. This is a non-responder. This is what you call a non-responder. This is the time where we'll have to sit back and think whether to change agent. Before you change an agent, always think of any confounding factors. Is there anything else happening by which the patient is not responding? Is there any coexisting disease? Is there any missing of doses which the patient due to the CNVM, you shift the agent. So I chose aflibercept. You know, it has got a longer duration of action, and it has got a better drying effect. I did not choose brolucizumab because there is I preferred aflibercept. So for 2 years, from 2019 to 2020, 2 years I'm managing this patient with aflibercept. Initially, I gave a loading dose of monthly aflibercept, followed by aflibercept every 2 months. So I'm keeping the patient, so they come once in 2 months, and I keep taking the injection. So I think there are a lot of events, so I'm cutting it short like a story. So in 2 years, what I see is I'm giving 2 monthly aflibercept, but sure and certain, by 1 year, I cannot sustain for 2 years. It is reducing to 2 months. It is reducing to 1 month. So slowly tachyphylaxis is developing for aflibercept, to a point that I give injection, and 2 weeks later also edema is not coming down. So in that point, I discussed the patient on brolucizumab because it is time for me to take the chance of an intraocular inflammation, if at all. The chances are rare though. The moment I give intravitreal brolucizumab, it is flat again, patient is doing well. But sure and certain, now I don't get 3 months, I get only 2 months. And to a point that it has reached a point where now I give once in 2 months, but it is drying. So that means from a non-responding case, now it is a responding case with a good response, but with brolucizumab. So here the eye itself is prone for tachyphylaxis, what I feel. And this is the recent picture. This is the pre-injection picture with the cystoid macular edema. It is flat now. The retroimaging on the top side shows neovascular complex. This is going to recur after 2 months. Here I have a subfoveal thickness, and the topmost slide, the subfoveal thickness of 193 microns. But with 5 years of treatment, I could maintain the vision from 6.6 only to 6.12 N6. But if I was more aggressive in treatment, I would have saved the fovea a little more, but this is the best that patient could do. It has got hyperreflective foci here, multiple hyperreflective foci, neurosensory detachment, as well as a massive edema. My first choice would be to give Osidex. This is a real world situation. The patient doesn't want to take Osidex because he doesn't want to afford. He cannot afford. So again, going back to biosimilars. Razumab is taken once, twice, not much of change in edema. His vision acuity is not improving. Now he comes back to me and say that now we'll take Osidex. This is a real problem that you face in practice. So now I take Osidex. It is dry. Within 3 months, it's dry and nice. The patient takes off. He doesn't come for follow-up. After 3-4 months, he comes back again. The edema is propping up. I'm telling him that the edema is propping up, but he is not interested in taking injections. Why? The visual acuity is good. Now, as the visual acuity is dropping, suddenly the gentleman wants to take, but he wants to take only Razumab. It's a common man who cannot afford injections, but somehow managing to. Why I presented this is I'm giving Razumab, and the edema is not responding completely, but I can see a small neurosensory detachment here, but visual acuity is maintained at 6.9. He is happy. He is coming to me for repeated injection, but he has his own time. Now, can we compare this to expert treatment that we get in our studies? Yes, this is the real world experience, but it is important to continue treatment like this so that the patient continues treatment with you to get the best for him. I know I'm exceeding time. My choice of agent has come to a point where helping the patient to continue the treatment, be it choosing an agent with lesser cost or be it increasing the interval between injections, but not forgetting the safety of the patient. Thank you.
Thank you, sir, for the comprehensive talk on choice of